Hey everyone, you're at the Silver Hill Grand Rounds presentation, and we'll get started in just a moment as people settle into the program. All right. Hello, everybody, and welcome. Thank you for joining us. I'm Dr. Jeff Katzman. I'm the Director of Education here at Silver Hill Hospital, and we are, as always, delighted to have you join us, where we're privileged to welcome Dr. Anthony Ahmed, presenting on the topic Behavioral Rehabilitation in Schizophrenia, Social Learning, and Beyond. I will have the pleasure of introducing him in just a moment. First, a little housekeeping. Our next Grand Rounds is on May 8th, when we welcome Dr. Kathleen Delaney from Nurses Week, who will present to us on the topic of mitigating workplace violence, turning the challenge into an opportunity. And we hope you all can join us and bring a friend. So for today's lecture, your questions, as always, remain an important part of our Grand Rounds experience. I will moderate a Q&A discussion with Dr. Ahmed at the end of his lecture, and this is really a great opportunity to put forward any questions or comments that you have, and you can submit them at any time during the lecture using the Q&A box at the bottom. If you wish to receive CME or CEU credits, please complete the evaluation survey that will automatically show up in your browser when we end the webinar. And we will also email a copy of the survey to all of you who are participating today. Finally, disclosures. No planners of this activity have indicated a relevant financial relationship with an ACCME defined commercial interest. And it is now my great pleasure and honor to introduce our guest speaker today, Dr. Anthony Ahmed. And Dr. Ahmed was recommended by many people on our staff. Can you please get him? He's amazing. So I'm so excited about this Grand Rounds, to be honest, personally, because Dr. Ahmed, you come so highly recommended by many on our faculty at Silver Hill. And to tell you about our guest, Dr. Ahmed is an associate professor of psychology in clinical psychiatry at Weill Cornell Medicine. He's also the vice chair for psychology in the psychiatry department and serves as attending psychologist in the psychotic disorders division at the Westchester Behavioral Health Center. Dr. Ahmed completed his doctoral training in clinical psychology at the University of Southern Mississippi, a psychology internship at the VA Maryland Healthcare System, University of Maryland, Baltimore. Dr. Ahmed completed a psychotic disorders postdoctoral fellowship at the Medical College of Georgia in Augusta University. He's involved in the development and dissemination of evidence-based interventions for people with schizophrenia. He also conducts clinical research, including collaborations funded by Brain and Behavior Research Foundation, NARSAD, the National Institute of Health, and PCORI, the Patient-Centered Outcome Research Institute. His clinical and scholarly interests include the phenomenology and treatment of schizophrenia and related syndromes. His academic work has been recognized by several scholarly and clinical awards. So with that, Dr. Ahmed, I'm going to hand the baton over to you and disappear for a little while you talk to us and enlighten us. And thank you again for being here today. And then I'll come back and we'll have some questions and answers.
Yes, thank you, Dr. Katzman. Thank you for having me. It is my pleasure to come in today and talk about the work that we do here on the Westchester Behavioral Health Center, particularly in our Second Chance program. I am an inpatient psychologist. The rest is details. Primarily clinician, primarily clinical in this department. And my work primarily involves people with schizophrenia. That's my primary area of clinical and academic interest. And that will probably be reflected in the tenor of this talk, which is going to focus primarily on services for people with schizophrenia and the work that we are doing in the Second Chance program. Okay, I have disclosures, but none of these are necessarily relevant to today's presentation. as this focuses on the Second Chance program. My hope is to talk about social learning as a model of rehabilitation and talk about behavioral skills training, which is heavily involved in what we do in the Second Chance program, and talk about some of the interventions and techniques that we use. None of these are necessarily new, but they are evidence-based, and they have a proven track record. That's why we use them in Second Chance. I'm going to talk about some of those interventions, and then talk about a few of the psychotherapies that we have incorporated into our programming platform. So schizophrenia is exciting to treat. It's exciting to work with patients who struggle with this syndrome, but it's also quite challenging. Patients struggle with a lot of symptoms, positive symptoms, negative symptoms, you name it. But they also struggle with a lot of cognitive impairments and disability, a lot of sometimes substance use issues are part of their presentation. A lot of patients struggle with fully engaging in treatment and remaining in treatment in an extended way. But a lot of our patients also struggle with, having resources in the community post-discharge. And, the story here is that schizophrenia, virtually everything is wrong for most patients, and your potential targets for interventions are endless, but the time that you have is very little. And so, but a lot of times in most settings, the length of stay that you have in most places that offer services for patients with schizophrenia is a matter of like maybe a week or two. So a lot of programs focus on stabilizing and discharging, but very few programs actually focus on the important work of psychiatric rehabilitation. Now we leave a lot of that sometimes to, outpatient clinical services, maybe in some cases, partial hospitalization programs. So the program that I'm going to be talking about today, the Second Chance program, is one of the very few programs on the inpatient side that are not state hospitals. Or even among, even inclusive of state hospitals, one of the very few that actually focus on, extended psychiatric rehabilitation. When you treat patients with schizophrenia, you begin with finding the right medications. Like, yes, that's where it begins, but that's not where it ends. Like a lot of patients struggle with, a loss of capacity in many different areas, and medications will improve some symptoms, but a lot of times there are residual symptoms that can increase their risk for relapse, and that can continue to contribute to disability in the long term. There's plenty of evidence at this point that tells us that psychiatric rehabilitative interventions on the psychosocial side can be beneficial for those patients. And I'm going to talk about some of those interventions that we've incorporated into our program. But the data really tells you that it's the synergy of medications and psychosocial interventions that really drive clinical outcomes. Like if you want to really make a difference in the lives of patients, you need some combination of medications and psychosocial treatments. And what's quite remarkable is how synergistic, those interventions can be. Like psychosocial interventions can target medication non-adherence, for example, or target some of the factors that contribute to medication non-adherence, like cognitive deficits, using that as an example. On the other hand, the right kind of psychiatric medications can really help patients gain from rehabilitative interventions or limit rehabilitative interventions, depending on the effect of the medications on the patients. So in fact, you find that a lot of medications that, have lower anticholinergic burden, for example, really help patients. But what some of the research literature tells us is that, the relapse rates are lower for patients who are on a combination of both medications and psychosocial interventions. Their clinical outcomes are better than patients who are on medications alone. We see that, for example, in the RACE study that was published about 4 years ago from John King's team, that shows that when you combine psychosocial interventions with medication management, not only do you need fewer medications, your long-term outcomes are better. But we also see that in studies of behavioral rehabilitation, um, the study by Rosenheck and the studies by Vedox were studies that focused on clozapine therapy, and of course those studies show that the combination of clozapine therapy with rehabilitative interventions actually was quite beneficial, and clozapine actually enhanced the effects of psychosocial interventions. Importantly, is that there's the possibility that you may need less medications or lower dosing of medications for patients who are also in psychosocial rehab programs. There is literature on best practices for what you should think about incorporating into rehab programs, like token economy based incentive-based programs or contingency management programs, some skills training interventions. So psychosocial therapies that really focus on enhancing, patients' deficits at certain skills, like their capacity to cope with voices or their capacity to engage socially with other people. Those kinds of skills-based interventions are part of what we consider best practices. I'll talk about a few of those. Behavior intervention planning that's individualized is considered best practice. That might involve some kind of behavioral contracting that's involved with like maybe the rewards that a patient might earn for a particular behavioral target or behavioral goal that you've established together. The use of positive reinforcement and some of those reinforcers like rewards and praise and whatnot are also considered best practices that have been shown for years to potentially contribute to rehabilitative success for this group of patients, as well as interventions to decrease particular kinds of behaviors, to decrease the likelihood of certain types of behaviors. So interventions like extinction plans or like prompting patients to change the action that they are engaging in, or using interventions like timeout can also be potentially beneficial. So yes, rewarding behaviors, but also providing some corrective kinds of feedback are also considered best practices. A lot of some of these techniques are based on theoretical models that have a long legacy in psychiatry and psychology. For example, operant learning is probably the most famous learning theory that's out there by B.F. Skinner. And central to Skinner's theory, which a lot of you have probably been exposed to in some capacity, probably in high school or in Psychology 101, is the idea that you can increase the likelihood of a behavior based on its consequence, if the consequence is desirable. So the consequence that increases the likelihood of a behavior is what we call a reinforcer. And you, in that sense, are engaging in reinforcement of that behavior. And consequences that decrease the likelihood of a behavior are what we call response cost. Punishment, for example, is a response cost. Not that I encourage the use of punishments, but just to kind of give you an idea. And these are ideas that Skinner certainly brought to our attention and operationalized for the field. In Skinner's model, there is a central role for the direct experiencing of that consequence. So according to him, in order to increase the likelihood of a behavior, the individual has to experience the consequence that comes with that behavior, for better, whether it's a pleasant consequence or an undesirable consequence. And that's what drives whether that behavior is going to be more likely to happen again in the future. And as the individual experiences consequences of that behavior, the relationship between the behavior and its consequence gets strengthened over time, right? And introduced ideas like positive reinforcement, negative reinforcement, extinction, differential reinforcement, which I'll talk a little bit about later on. As I mentioned before, positive reinforcement, like if you increase the likelihood of a behavior by providing something desirable, that's positive reinforcement. If you increase the likelihood of a behavior by removing something that's undesirable, something that the patient wants removed, for example, that's an example of negative reinforcement. And of course, response cost is when you decrease the likelihood of a behavior, by the outcome. So if the outcome is, the individual experiences something that's undesirable, that would be an example of what we call positive punishment. Negative punishment technically would be you decrease the likelihood of a behavior by removing access to something that the individual may find pleasant or desirable. That would be a kind of negative punishment. Those are response costs kinds of interventions. However, I, you know, what really replaced or what really, as a theoretical model, what really drives, I think, in my view, most kinds of learning is what we call social learning. Okay. Social learning theory is another important learning theory. It was proposed by Albert Bandura. And the idea there is that, social learning drives probably most of the actions that we learn to carry out, like the language that you speak, for example, the cadence with which you speak that language, the cooking actions, very complex skills that you know how to do, come through some form of social learning by, usually the idea here is that, all learning can occur vicariously, not just through direct experience. Like Skinner believed that you have to experience the outcome to actually, learn the association between that action and its consequence. But, Bandura argued that actually you can watch other people engage in action and experience consequences, and then encode that in your mind, and use that to drive your future behavior, and, in this sense, there is a central role for your observation of the behavior of other people. So for a patient, there is a central role for the patient observing other patients in your milieu, experience, outcomes for their behavior. And Bandura argued that, unlike what Skinner was proposing, that this is a more efficient way for human beings to learn is through observational and vicarious learning through other people's examples. So the idea here is that, people learn because they see. People see and they do, right? And people copy other people's actions. And because they are encoding the consequences of other people's actions. Okay. And for Bandura, the relationship between an action and what happens after that action, whether it's a reward or whether it's an undesirable consequence, that gives information. There is information that the individual stores in their mind, and in that sense, the mind and mental processes are important for determining whether an individual is going to engage in an action. Okay, if they remember that that action leads to consequences that they like, they will engage in that action. They'll reproduce that action. So, in that sense, there's always a model. Okay, the model must capture the patient or the individual's interest. Okay, they must think that there is something about what that model is doing that they want as well. Maybe it's the reward. So if, for example, if a patient gets attention from all of the staff members in your milieu, when they pick up a chair and throw it across the hall, if that patient, that's observing, if that patient wants attention from staff members, then they will encode the relationship between picking up a chair and throwing it across the hall and getting staff attention, getting all of the staff in your hospital to rally to provide support. So there is a focus on the on the model and a retention, okay, of the action that model engaged in, like picking up a chair and throwing it, or, dressing properly and getting praised for dressing properly. Okay. There is a retention of that action and its reward. And for the patient who is observing, there is a need to reproduce that action. Okay. Whether through practicing that action, mimicking that action, and receiving feedback for themselves as well. okay? And the feedback they receive could be in the form of a reward, okay, for replicating that action, or like a negative consequence for replicating that action, okay? And in that sense, that drives the motivation for the individual to replicate the action that they are observing. And that's really what Bandura demonstrated in his own research studies and proposed in his theory. And this has a lot of potential because a lot of natural learning happens this way. Okay, like infants, for example, like you smile and they smile. Okay, you know, like you pick them up and do baby talk and they try to respond. There is learning. That's how ultimately they are going to acquire language. And then in a couple of years they're standing in front of an audience and giving a grand rounds talk. Right? It all begins with some basic social learning through a baby focusing on their caregivers and replicating their action. Okay. And another piece of this theory is that, it extends into how we engage in psychiatric rehabilitation. So the process model of psychiatric rehabilitation proposed by Pat Corrigan, for example, sort of lays it out that there is, a need for, rehabilitative programs to have, to facilitate, the learning of, information, learning of skills through acquiring, techniques, that they have lost and relearning those techniques. And then there's a need for those programs to not only provide an opportunity for them to acquire those skills, but there's a need to motivate patients to perform those actions or perform those skills, in the treatment environment, so that you can promote ultimately their performance in the community, right? And that process of performance and generalization into the community, as well as acquiring, the learning can also be driven by, the patient's cognitive capacity. So rehab programs should also include interventions, particularly with patients with schizophrenia, interventions that address the cognitive deficits that might get in the way of how the patient, encodes and stores the information about, like the action and its consequence that they're observing in the model. Okay, so a couple of principles that we can put together from this social learning theory about teaching patients skills. Okay, a couple of things. If you want to teach your patients some skills, you want them to learn how to do deep breathing exercises, DBT skills, like whatever skills you're trying to teach them how to do. A couple of things you have to do is, number one, you have to provide a model for the skill that you want them to learn how to do. Okay, you have to demonstrate it preferably. My suggestion is always to take that skill and break it down into individual steps, okay? And then get them to pay attention to each step of that skill that you're trying to teach them how to do. That's step number one in modeling, okay? Because again, remember in Bandura's model, there's an impact of attention, okay? If the patient doesn't focus on the model, then there's nothing to store or to encode. So you want to make sure that all of the steps of the skill that you're teaching them to do, that you're breaking it down and focusing their attention to those steps, either through discussion of the rationale of the step. Okay, I'll show you an example when I talk about some of the groups that we run in the Second Chance program. Step number two is that you need to create opportunities for them to rehearse. Okay, they need to practice the skill in session. Okay, use visual prompts if you need to, use coaching if you need to, but you need to get patients to practice the skill. Okay, and while they're practicing the skill, provide a lot of positive reinforcement, positive feedback in the form of praise, for example. Oh, great job, keeping your eye, making eye contact. Great job making eye contact while you were trying to start a conversation with me. You want to give them positive reinforcement as they engage in those skills. Number three is that you want to create opportunities to repeat. You need to create opportunities for repetition. So the skill that you're having them practice, you need to practice with repetition. Okay, practicing one time is not enough. Okay, the goal of practicing is that the more you practice, the better you get. So that increases mastery, and then you provide corrective feedback. And then you scaffold, you increase the challenge. Okay, so over time, you might say, okay, good job. You are now doing a good job starting a conversation with one person. This time, I want you to start a conversation with two people. We're going to practice starting a conversation with two people. And then next time, we're going to work on practicing starting a conversation with a group of people. Okay, so you're scaffolding the level of challenge. And then, whenever possible, provide some stress induction. Okay, provide some opportunities to practice under like slightly after they've gained some mastery, have them practice under duress. Okay, so if you're teaching patients relaxation exercises to self-regulate, okay, this time provide have them practice when they are stressed out, okay, or when they maybe when another staff member made a rather when another staff member made them upset or another patient made them upset, you're like, oh, this is a good time for us to practice the skills that we worked on in session yesterday. Okay, and then have them practice in many different situations because that's what's gonna help them think about generalizing into other contexts. Now, in terms of your rewards that you incorporate into, practicing with patients, those rewards can be social. It could be like attention, for example. They could be tangible rewards like chocolate kisses, if that's allowed in your program. There could be access to certain types of privileges. There could be all kinds of rewards. And it's important as well. Another lesson to kind of pull from social learning theory is that we need to be mindful of what patients, are encoding in their mind. Okay, when you have a rehabilitative program, patients are watching other patients, they are watching staff members, they are watching dyads between staff members and patients, and dyads between patients and other staff members, and they are encoding that. Okay, so we want to be mindful of the kind of messaging. So, for example, patients can easily internalize the wrong kinds of associations between action and consequence. Okay, and patients a lot of times remember, surprisingly. So every interaction that you have with a patient in your milieu is a teaching moment. Okay, there's an opportunity to model, there's an opportunity to praise, there's an opportunity to give corrective feedback. Okay, when you're teaching patients skill, don't just tell them do your breathing exercise. Okay, you say let's do your relaxation exercises, let's do it together, do it with them. Don't just tell them to do it, and then don't do it for them, do it with them as well. All right, and be generous with your rewards as much as possible, especially at the beginning. And in rehab programs, we generally underscore making sure that patients are getting our attention and getting our time when they are doing really well, not just when they are struggling, because of the kind of messaging that they can encode from the relationship between being in crisis and getting staff attention, for example. Like this is from Paul and Lenz, like this is one of the very first studies that looked at a social learning rehab program. And Paul and Lenz essentially showed that in long-term stay hospitals who were treated in a social learning program had higher discharge rates and compared to people in traditional milieu-based programs and patients in other types of traditional treatments. And their social outcomes were also much better in terms of improvements in their social and occupational functioning. Hopefully, I have time at the end to maybe talk about some of the data from our second chance program as well. Okay, the second chance program. We've been around for about 25 years. This is our 25th year, going on 26th. Started in 1998. This really started as a collaboration between Weill Cornell Medicine and New York Presbyterian Hospital and the New York State Office of Mental Health. And the plan there was to really target patients who were difficult to treat that were remaining in state hospitals. So a lot of the patients that we were taking at the time were really patients who have been long-term hospitalized in state hospitals. So we were taking patients from state hospitals, providing rehabilitative interventions and sending them back, and our focus was, over time was to, focus on rehabilitation of assaultive behavior, work with patients who were most likely to engage in assaultive behaviors, patients who were struggling with, adhering to treatment, and struggling with their ADLs. Those were a lot of the patients that we were accepting in second chance program. We still accept a lot of those patients, but over time, as we've tried to push down our length of stay, uh, we've focused more on getting patients from acute inpatient settings, not just patients from state hospitals. We have 23 beds currently. We used to have 30 beds. We've decreased our number of beds, but we're still accepting some of the same kinds of presentations for the most part. We used to take a lot of chronic patients. We still take patients who are chronically ill, but we've also over the years also focused on accepting some patients in the early stage of psychosis as well. These are some of the evolutions. We provide a lot of, we view ourselves as a recovery-based program. Yes, we are a social learning token economy-based program, but we've created an iteration of that model that I believe is very patient-centered, that focuses on patient engagement and focuses on working with patients to identify their own goals, their own rehabilitative goals, their life goals, their valued social roles, and incorporating that into, how we work the program on their behalf. Our goal ultimately is to teach adaptive skills, social skills, communication skills, living skills, so that patients can operate as independently as is possible in the community. And we also provide a host of evidence-based psychosocial interventions as well, like cognitive remediation and CBT for psychosis, and a lot of skills training groups and so on. The primary diagnosis is a psychotic disorder, primarily schizophrenia or schizoaffective. Most of our patients come from the New York City metro area, even though we are in Westchester. A lot of our patients some of them are on polypharmacy or on clozapine therapy. They may require some delicate behavior intervention planning. Most of them have a comorbid substance use problem, and they have limited resources. And so part of our discharge planning is a lot of times to get them those resource supports when they get discharged. Some of our treatment targets, this is just a few of them. We target certain deficits like ADL issues, sedentary behavior, lots of, focus on negative symptoms. Our patients struggle with a lot of severe negative symptoms, but behavioral excesses as well. We have patients who struggle with aggression and impulsivity and, inappropriate sexual acting out behavior and other challenging behaviors. Again, our eligibility criteria, we generally want patients with a primary psychotic disorder diagnosis, preferably patients who've tried other inpatient settings and have experienced lots of hospitalizations. It's always helpful to us to have a clear target for improvement, a clear rehabilitative target when we admit patients into our program. Our program has 3 levels of interventions. There's the milieu level, which is based on the social learning model and operant behaviorism, as I discussed before. There are group level interventions in the form of those evidence-based psychotherapies, and there are individual level interventions like individual therapy, medication management, psych evals, individualized behavior planning, and so on. The milieu therapy is where we get the most bang for our buck. We view every moment-to-moment interaction between our patients and staff members as, the critical aspect of treatment. It involves both the modeling of what we consider appropriate behavior that the patient is going to encode from staff members and from other patients as well, okay, from the entire milieu. That's a big part of what we're trying to do. We view those as important active ingredients in terms of what leads to rehabilitative success in our program. The majority of improvement happens at the milieu level. And I'll talk to you about these are some of the interventions that we leverage at the milieu level. Obviously, there's a token economy system that we use, okay, as a program. It's essentially our primary technique, but it's also a points program. So patients earn points for, you know, a lot of actions, a lot of appropriate behaviors, like having conversations with their peers, engaging in independent activities. You know, we as a milieu, we train our staff members to um, target those adaptive behaviors and reinforce and reward those adaptive behaviors with our point system, so that those adaptive behaviors increase in frequency over time. And then part of what we do, which I'll show you what that looks like, is that at the end of the week, the patient receives a report that shows their performance the previous week, the number of points that they accumulated in adaptive behaviors, the areas where they lost points, you know, for example, for engaging in actions that won't be desirable in the community, they lose points for those actions. You know, patients get to see the frequency at which they engage in both adaptive and undesirable behaviors. You know, and you know, the report gives them, you know, in a way, like, you know, timely information about their own progress in the second chance program, and they are able to redeem both the tokens and the points for all kinds of rewards. Okay, so for example, the tokens can lead to being having, being able to redeem like tangible rewards from our token store. For example, we have a token store that's a lot like a grocery store, that a lot of our patients look forward to actually, you know, leveraging and using their and spending their tokens. So the tokens are like currency in the program. And you know, the point system is going to give the patient a sense of what kinds of privileges, hospital privileges, they are going to have that week. For example, patients who are at our highest levels are able to go off the unit, go on community skills trips, you know, go to the cafeteria that's in the hospital. So the points reflects their absolute performance level and rehab level in the second chance program. You know, so this is what the tokens look like. Again, as you can see, we designed it to look exactly like currency. You know, and you know, the tokens can be redeemed in the token store. As I mentioned before, you can rent the MP3 players, you can buy items in our token store. You know, and you know, you can either, earn tokens for completing your ADLs, for attending groups, for taking medications, for meeting your ADL targets. You know, and then the points, the points, of course, will determine whether you get to go outside, go off the unit, go on community skills trips. These are some of the adaptive behaviors that we target: exercise, independent activities, activities with other people, coping with stress, you know, encouraging your peers on the unit, telling your peers about what they need to do well in the program. So sharing as a form of altruism is really encouraged in the program. Sharing information as a form of altruism, helping staff members to keep the milieu, well for everyone in the milieu. You know, responding to feedback from staff members also gets rewarded. So we encourage our staff members, we train all of our staff members to target all of this, you know, potential desirable behaviors, you know, and use their initial to mark, you know, the frequency of those desirable behaviors. And then some undesirable behaviors like as well, like behaviors, typically behaviors that a lot of patients present with, behavioral excesses, as well as deficits that are in need of rehabilitation. So we'll tell our staff members to, you know, if the patient engages in one of those behaviors, to give them feedback. It's a teaching moment, give them corrective feedback. You know, now they might get marked down for that behavior, but if they respond to the feedback, then you reward them for responding to your feedback. Okay, so this is what we use for corrective feedback in the program. Okay, so we have, targets around ADLs and self-care, like we have laundry targets as well, and so on. A lot of behaviors that our patients are expected to engage in when they get discharged into the community are our targets. Okay, patients get a report that looks like this, that tells them the frequency of each one of those actions and the total points that determines their rehab level for the week at the bottom of the page. So this is a synopsis of the report that patients get. Like, we have conversations with them, we give them feedback, we engage in a very collaborative discussion about how to improve their points the following week, what areas to focus on as well. So these are some of the rehab levels, depending on the number of points that they accumulate in the program. You notice that the diamond level, they get to walk outside the building. They can visit family, or traditionally they can visit family during the holidays. They can go on community passes. They can go on community trips and so on. So they can go to the cafeteria and so on. So each rehab level has particular privileges that it confers on the program. So some of the milieu-based techniques that we train our staff to use include positive reinforcement, three-step prompting, extinction, timeouts, differential reinforcement. I will explain briefly what those are. So when we ask our staff members to provide positive reinforcement, a lot of times it's in the form of praising the patient for engaging in pro-social behaviors. We ask our staff members to be effusive in their praise, and be very specific about what it is that the patient is doing really well. Link it to material, something tangible if possible, like a gift or a reward. Importantly, we encourage our staff members to find something that the patient is doing really well. Find the gold nugget. There is something, and you don't really have to look that hard. There's usually, even for patients who struggle, there's usually something they are doing really well. And then the three-step prompt. So the three-step prompt is what we teach our staff to use to correct behavior. Okay, we discourage nagging patients. We discourage insisting on compliance. Compliance is not the point. Okay, compliance is more often than not, trying to go for compliance is not only an Herculean task in a lot of cases, it's also kind of, a lot of times it can lead to escalating the behavior, the patient getting frustrated with the staff member. So we usually encourage our staff members to use something called the three-step prompt, which is a very neutral way to give corrective feedback. Okay, in step number one, you reflect the patient's intention or the feelings, if there are feelings involved. You state the limit or the consequences as briefly as you can, and then you suggest an alternative strategy, or you elicit an alternative strategy from the patient. Okay, so this is a kind of redirecting of the patient to engage in something that's much more pro-social, and that is the teaching moment when you give corrective feedback. The goal is not, again, to force compliance. Our goal is the big picture. Our hope is that through the consistent receiving of the three-step prompts or corrective feedback over time, that learning happens. Okay, it's not about compliance with that one action, but that over time the patient understands and they learn, what's expected in the community, and they through the three-step prompt and the positive reinforcement, elicit what is expected in the community over time. This is an example of a three-step prompt. In step number one, this is a patient who raises his voice. John, I can see that you're upset. In this program, when people are upset, they don't swear at others. People who do may lose privileges. In the community, people may think they want to fight. Then step number three would be something like, do you think this might be a good time for you and I to, maybe practice one of the coping techniques that we worked on yesterday? Or do you think this might be a good time for you and I to go to the nursing station and talk to the charge nurse about getting a PRN medication? Again, or what do you think might be a better way to respond in this situation? So that would be a step number three. Again, you're prompting an alternative strategy. Extinction is another intervention that we use. Usually this is coordinated with all of the staff members in the program. If we're going to use extinction, you can't have one person do it. Everybody has to do it. So it's usually part of a specialized behavior plan. When you do extinction, essentially you're ignoring their inappropriate behavior. So for example, if a patient has a propensity to ask questions that are too personal, so you might use an extinction plan to ignore that action so that you're not inadvertently reinforcing asking inappropriate questions. And a lot of times when you start an extinction plan, you might see an escalation of the behavior, like when you start ignoring the behavior, because that behavior had been reinforced for a long time. So the patient is going to try it over and over again to try to understand why it's not working this time. Okay, so we call that an extinction burst. Okay, but over time, just hanging there over time, that behavior is going to decrease. Now, in the future, there might be a spontaneous recovery where the patient tests it out again. But if you just remain consistent, during that spontaneous recovery, the result will be an extinction of that maladaptive behavior. Okay, and then we also use timeouts. Timeouts is something that we socialize the patients to as an intervention from the get-go, from the time they get admitted into the program. And the idea of the timeout is, we will usually, if the patient engages in an action, for example, that could be inadvertently reinforced, we'll ask them to take a timeout from the milieu. So the timeout might be in the quiet room, or it could be in their own bedroom. We'll give them the option or the choice. And it's usually a 5 to 10 minute kind of timeout to sort of, again, not get reinforced with the program for engaging in that behavior. So as an example, if you have a patient who jumps the line during snack time, you definitely want to ask them to take a 5 to 10 minute timeout, because you don't want them to inadvertently associate jumping the snack line with getting the snack. Okay, that would be, that would be a good thing from a therapeutic standpoint. So timeouts are a common intervention. Differential reinforcement is built into everything that we do. We believe that the more you reinforce, appropriate actions, you might indirectly see a less occurrence of, some of the maladaptive behaviors. Okay, so we always encourage our staff members to kind of look out for opportunities to reinforce patients making requests the right way, engaging with peers the right way, so that way, we're not deploying our resources exclusively to occasions when the patient is struggling or engaging in maladaptive behaviors. Okay, fading is incorporated into our milieu. So fading in the sense that over time, as the patient starts to consistently show improvements in the behavior, we start fading rewards. We start decreasing the occasions in which they are rewarded for that action, because we want them to engage in those behaviors independently. And we want intrinsic motivation to, if possible, take over as well. So over time, part of our fading might be to prompt them, decrease the occasions in which we actually prompt them to do things, or occasions in which we actually praise or reward them for engaging in actions. So we want to decrease that over time so that they're engaging in those things or those actions independently. We fade out the tokens. The point system is still operating on the backdrop, because that's what's going to determine their rehabilitative level for the following week. So so that's still there, but a lot of the reinforcers are decreased over time. So this is based typically on the patient showing consistency. So once we're seeing improvements, then we start to fade those things out. Okay, so a couple of quick points about how we operate the program. It's a completely voluntary program. We generally encourage referral sources to make sure that if patients are going to come to second chance, that they are voluntary, because we want them to be able to have access to all of the rewards and benefits that the program can offer. And a patient who is admitted on an involuntary status can be let off the unit. So we want them to be voluntary. And because the voluntary status also allows us to really engage in shared decision-making, collaborative goal setting with the patient, and setting goals and timelines for them as well. We, as much as possible, we link all of their actions to rewards and privileges that they like, okay, that are patient-centered, that are patient-informed. So we have a community meeting on the unit, for example, every Monday that allows us to receive feedback from all of the patients in the program about what they want us to do better, about what privileges they want us to incorporate into our program. So the customer service aspect is something that we try to underscore. And we try to, as much as possible, use focus on positive reinforcement and less on response cost. We try to limit our use of timeouts, our use of extinction. Those are almost very last resorts. So our primary interventions are positive reinforcement and the three-step prompt. Okay. And that allows us to, again, make it a very, as much as possible, patient-centered. We limit our use. In fact, the program is probably the best program in the hospital in terms of holding our staff members accountable for, the feedback that they give patients, but also probably the best program in the hospital at the use of restrictive interventions. We very rarely use, seclusion and restraints in the second chance program, despite the population. And whenever possible, we try to encourage patients to choose their own rewards and their own privileges. So in terms of maintaining the fidelity of the program, a couple of things that we do is we provide a lot of staff training. We have workshops and annual retreats with our staff so that we can make sure that everybody understands the model and everybody understands the rationale of the model. We test how staff members are doing at implementing those techniques during our retreats, and we incorporate our fidelity monitoring process that's often led by our psychology grad students to kind of go through the unit, make sure that staff members are praising patients, catching patients, engaging in pro-social behaviors, and giving staff members feedback as well. It's part of what we try to do with monitoring our fidelity. And then we have our staff members complete performance improvement projects. Our nursing staff have several of those that they've presented to the larger hospital, again, as part of an important intervention. Okay, all right, so group level interventions. So at the second level are the groups, and the goal here is to target, help our staff, our patients acquire skills that are going to be necessary in the community for managing residual symptoms, for coping with stress, for managing or enhancing their emotional regulation, for improving their cognitive functioning, their social skills, and their community performance. A lot of these groups are manualized evidence-based interventions. We have substance use groups. Some of these are patient-led groups that are, focused on, like engaging in recreational activities. Some of these are healthy lifestyle groups like exercise and so on. As you can see, it's a fairly comprehensive platform. This is about 50% of the groups that are available to patients in the program. This is just hopefully a good representation. I'll talk about a few of them because I want to underscore how a few of them leverage some of the principles from social learning theory. I'm going to talk about a few of the evidence-based therapies. Cognitive remediation, which a lot of you probably have heard about, focuses on thinking skills. The goal is to increase, cognitive functioning as well as social, community functioning, and, we leverage this intervention to create a platform for patients to not only train their cognitive skills, like their memory, their focusing ability, their problem solving skills, their quick thinking skills, using computer software. We use a lot of computer software. I won't go into which ones we use, but there are lots of software that are out there that follow the principles of behavioral training. A lot of these interventions are drill and practice kinds of interventions where, like, for example, the patient is asked to remember a list of words or remember some facts, or solve a puzzle. And then over time, those games or those training tasks will increase in their level of difficulty as the patient gets better, usually keeping the patient at about 80% performance, like at a B plus, if you will. And, there is a lot of the data that shows that this is a very useful intervention. For us, we not only have patients trained on the computer, but we also create these talk sessions that we call bridging groups. or that are called bridging groups. I didn't invent it. This is out in the literature. And it gives patients an opportunity to talk about thinking skills, talk about how to improve their thinking skills, trade and share ideas with one another. It gives us an opportunity to teach patients strategies for, how they, leverage those thinking skills. There are lots of protocols that are out there, like if one of the ones that is well published is Thinking Skills for Work by Susan McGurk. That's that we've used, that we found to be very useful for our patients. Uh, there are protocols that are out there that we've also adapted from our compensatory cognitive training. Um, you know, and like yeah, and so essentially again, like we've created our own protocol that's adapted from many different sources to sort of lead this kind of group discussions about thinking skills and how to connect those thinking skills into many different situations that you might encounter in the community. There's data like this the most recent meta-analytic study looking at the benefits of cognitive remediation. So you see that like you get like the small to moderate range effects on global cognitive skills. That's the equivalent of probably about 8 to 10 IQ points, if you will. And we found that, like, in fact, there's a paper that was published recently that by Matt Codd's team that shows that like bridging groups actually had remarkable benefits to the drill and practice that you do in cognitive remediation. So those bridging groups actually had substantial benefits in the sense that you get more bang for your buck when you provide the cognitive remediation with the bridging skills group. Okay, so social skills training is another one. We use a model that was developed by Alan Belak and Kim Musa and their colleagues. And the social skills training targets some of the social skills deficits that patients with schizophrenia might have. It involves a lot of, social learning in the sense that, like, yeah, patients are, practicing, they are rehearsing, they are doing role plays, they are watching, when you're doing social skills training, you're demonstrating the social skill that you want patients to learn, and then you're coaching and prompting them, and you're using a lot of praise and a lot of positive reinforcement to encourage the performance of those social skills. And then you're having them practice repeatedly in social skills training. And yeah, in that sense, it capitalizes on a lot of ideas from social learning and a lot of skills training ideas. A lot of the meta-analytic studies show like very significant effects on areas of social functioning. Including their capacity to master the content of that particular skill, and their ability to actually, perform the skill, in daily living situations. You get quite remarkable effects in terms of the benefits of social skills training. These are for us, this is like the sample of our curriculum. These are some of the skills that we've adapted from Alan Belak's protocol, his manual. Some of the skills that we work with our patients or work with our patients in group. Asking someone out to date for a date is a very popular one. Making apologies, responding to untrue accusations, maintaining conversation, like, yeah, you name it. And sometimes part of what we do is we work with our patients, to actually create the curriculum. So that allows for some shared decision making. I want to talk just briefly about chaining as a technique, or chaining as a principle. Um, Essentially what you do in chaining is you take something that's very complex, a complex skill, and you break it down into many different steps. Okay. And then you teach each one of those steps that the component steps of that broader skill, and you teach those component steps, and you have patients practice each one of those steps, and then you reward them for putting all of those steps together. And a lot of skills training interventions, a lot of skills training groups leverage that, including social skills training. So, for example, when we work with patients around finding common interests in social skills training, we break down into 4 steps. This is from Alan Belak's manual. It's broken down into 4 steps, and the therapist demonstrates the skill. That's the modeling aspect of it. You would talk with, and then you would practice each one of those steps, in front of patients, and then you will have patients give you feedback on each one of those steps. That way, they are focusing on you. They are focusing on you as a model. That helps with their attention. And then when they do it, you have them go through each step and, practice each step with feedback, both positive feedback as well as some corrective feedback as well. So yeah, this is a technique that's very useful for teaching complex skills, is this idea of training. Okay. Functional adaptation skills training was developed by Thomas Patterson, and it's another kind of skills training intervention that we adapted. It was originally developed for older patients, but we adapted it for our lower functioning patients, and we added to Thomas Patterson's protocol, we added some additional skills, which I'm going to show you. It uses a lot of props and a lot of simulation of community-based situations. So I'm going to talk about our curriculum in a minute, but there's pretty good, there's some data, like there needs to be more data, but there's some data on the benefits of this intervention, in older patients with schizophrenia, so patients above the age of 55, 56, that shows that this skills training intervention contributes to improvements, in this case, in patients' ability to carry out some of those independent activities or independent functioning skills that they may have lost, as a result of the syndrome. So for our patients, these are some areas of independent living skills that we work with them around using this functional adaptation skills training idea. We work on domestic skills like sorting your clothes, tidying up your room, making your bed, room cleaning, setting a table, clearing a table, calling 911, using some of this, using technology to communicate, writing a letter, sending an email. Like those are some of the skills that we work on. Like I said, we use a lot of props. So when we work on domestic skills, for example, we bring a rollaway bed into the group room with bed sheets and everything, and we practice with patients, again, following or using the principles of social learning, like, modeling the skill, demonstrating the skill, and then using chaining to break the skill down into its component parts. So yeah, as you can see, this is a very comprehensive curriculum. It includes financial management, how to write a check, how to count money, and so on, how to do your grocery shopping, how to call in your medications, how to use a kiosk, a Grand Central Station. We have, that's part of our curriculum now as well. This is an example of, a group activity, like sorting your clothes. Like we break that down into 4 steps, and we work on each one of those steps in the group. Okay, CBT for psychosis. We created a CBT for psychosis group that's very that focuses a lot on skills, because of the cognitive limitation of cognitive deficits that some of our patients experience. We decided to sort of create a very brief curriculum for CBT that bypasses some of the cognitive limitations, and that capitalizes a lot on practicing things. And when I get into the curriculum, I'll explain that a little bit further. When we do CBT for psychosis, we incorporate a lot of in-session role plays. So what kinds of CBT skills can you use, for example, when you're hearing voices? And we practice those. We demonstrate those in group. And we leverage principles of skills training, scaffolding, and so on in order to help patients improve those skills that we typically teach in CBT. Our curriculum includes three components: mood management, coping with voices, and managing suspicious thoughts and beliefs, what you might people typically call delusions, but we don't use that term. And in our coping with voices model, for example, we work on using distraction techniques like, using, and we use, like using headphones, for example, like, you know, uh, reading, a passage from a book to distract yourself from voices, and when we do that in group, we do role plays where we simulate voice experiences. So if I'm running, if my or my grad students are running the group, for example, or one of our social workers are running the group, like we will stand behind the patient after we've taught them the skill. Um, we will stand behind the patient and we will simulate voices. Sometimes other patients will simulate voice experiences, and the goal would be for the patient to engage in that skill that they've learned in the group while they are hearing, while we are simulating the voice experience. So yeah, so he leverages a lot of principles from behaviorism and social learning to work on these kinds of CBT techniques. So I'm going to, in the interest of time, I'm going to move on. Like I said before, these are just some examples of some of the behavioral techniques that we leverage, like listening to music, humming or singing, reading forward and backwards, talking to someone to distract yourself from voices. Or sometimes it's the technique might ask you to focus on the voice. So for example, when you use sub-vocalization, when you hear the voice, repeat what the voice said, but with a lower volume, and then progressively use your voice to dial down, the volume of the voice. And when patients go through that, when we practice it with them, they suddenly realize that, voices or voice experiences are not completely, out of your control, that you could use something as simple as sub-vocalizing or sub-vocal speech to dial down the intensity of voice experiences, and we use role plays to practice those techniques in groups, as well as other techniques for self-soothing, like relaxation exercises and so on. And we do the same thing with, using evidential analysis. So, in delusions, for example, one of the important CBT techniques is thinking about the evidence for and evidence against the belief. Okay, we teach patients that, when we do our evidential analysis in CBT, the focus is not necessarily on getting the patient to change their belief, because traditionally that's what you think about when you do CBT for psychosis. Our focus is on changing how the patient, you know, comes to their belief, changing how the patient, synthesizes information. A lot of patients with schizophrenia jump to conclusions, okay, informing their beliefs about their experiences, okay? And so we teach them how to collect data, how to look for evidence against. We practice that intensely in therapy, and we practice how to think through alternative explanations for the same kinds of experiences, and we use role plays to do that. We use activities to facilitate that. So for example, we might do an activity like, if somebody the therapist might say, you know, I am the great basketball player, Michael Jordan. What are some evidence that would suggest that that's not true? So we might use that kind of interactive activity to train patients to look for evidence that, or rather look for contravening evidence to a particular type of belief. Okay, and then how to set up behavioral experiments as well to see or figure out whether a belief is justified. Okay, we also have groups that focus on, getting patients ready for discharge, like wellness recovery action planning, which allows patients to kind of, create their own wellness toolkit and come up with their own wellness plan. We go on outings in the community. We, as much as possible, we try to create some simulated work experience for patients in our hospital. We used to have a comfort zone, which, as a result of COVID, the comfort zone is a gift shop in our hospital that provides work experience for our patients. We kind of had to pause that because of COVID. We're hoping that at some point that's going to return. We have a discharge group where patients talk about preparing for the community, where we talk about some of their anxieties and some of the challenges, and then we go on a lot of community skills trips, which allow us to, which give us, you know, um, some information about how patients are in terms of their readiness for discharge. So the purpose of the community skills trips is to, you know, sort of aid that community reintegration piece of rehabilitation. It allows or creates an opportunity for patients to practice some of the skills that they've learned in the program during the community skills trip, for example. And an opportunity to experience stress, and sort of get some exposure into the community. We take them to places like Stop and Shop. We take them to places like the Salvation Army, Barnes and Nobles, the Dollar Store, like a local diner. Like we take them on those kinds of trips again to ease them out into the community, and get data. A lot of what happens after patients return from the trip is like we debrief with patients, we debrief with the staff that escorted them on those trips to kind of figure out like the patient's readiness to leave the hospital, or if there are additional interventions that we need to put in place to get the patient at a point where they are ready for discharge. It involves a lot of preparation. We have patients anticipate going on the trip, like up to like several days to a week ahead of time, so that they can think about it, prepare for it, get excited about it, and we provide on the spot like support because they are escorted by staff to those places in the community, and then we communicate as a team about information that we gathered from the trip. These trips are usually about 2 to 3 hours. So these are extended trips in the community. Um, so individual level interventions, like those include medication management, ECT, individual therapy, psych evaluations, case management, and so on. I want to focus a little bit on the functional assessment and the behavior planning, and the shaping piece before we get to the end. Um, individualized behavior intervention planning has several steps. I think it involves understanding the situations, like these are important for patients who may have particular difficulties or challenges that the milieu interventions can't handle. So this patient needs a specialized behavior plan to kind of um, you know help them learn new behaviors and behave more functionally. So so it could be a behavior like interrupting other people's conversation or like touching other people and so on. And so we try to understand the root cause of that behavior. Root cause in the sense that, well, do we know what situations the behavior is most likely to occur? We try to get an assessment of that. We try to understand what the patient gets out of the behavior. In other words, the function of the behavior. And then we collect data. We collect very careful data. Um, and based on the data, we will create an intervention plan that's informed by our understanding of the function of that behavior. In other words, the meaning of that behavior for the patient. What does it get them? When they engage in that behavior, we write the behavior care plan, we implement the plan, or we test out the plan as a staff, and depending on how effective the plan is, we revise as necessary. And once we know what the behavior looks like and its early warning signs and the consequences that maintain the behavior, we would come up with a behavior intervention plan for the patient. More often than not, the function will usually be one of these four categories. The patient is engaging in behavior because it feels good, or because they get to escape from a demand, or because it gets them attention from staff, or because it gets them something that they like, some tangible commodity on the milieu. So the intervention plan would include prevention strategies. It's going to include some kind of extinction where we're making sure that they're not getting that desirable outcome from engaging in the maladaptive behavior. Then we teach them new behaviors. We teach them adaptive behaviors and make sure that we are rewarding the more adaptive behavior. And then we generalize, we work on generalization as part of the behavior intervention planning. This is an example of a result from the behavior intervention plan. You know, as you can see, like for this particular patient who engaged in a lot of intrusive behavior over time, the frequency of the behavior decreased as we implemented the plan over time, as we put the patient through both the milieu and the specialized behavior intervention plan. And the patient's points went up over time from negative points in the program to the highest privilege level in the program. Just to kind of show you a sense of the kind of data that we collect and how careful we collect data. So real quick, I'm keeping my eye on the time. We do some specialized, shaping in the program as needed. And, what's involved in shaping is that you will essentially reward a successive performance of a targeted behavior. That target could be, focusing your attention, and for a patient who is very distractible. So you might create a behavior plan, a shaping plan around focused attention for that kind of patient. In fact, attention shaping is something that we've published a lot of, from the Second Chance program. Attention shaping was an intervention that one of our founding members in the Second Chance program, Steve Silverstein, created. And essentially, it involves operationalizing what good attention means, and making it measurable for the patient. So and then once you've created an operationalizing of what focusing and attention is, it could be focusing your attention in group, for example, or focusing attention in morning rounds. Once you've operationalized it, you would figure out a way to measure it. So focused attention could involve, for example, attentive behaviors like keeping your head up, keeping your eyes open, keeping your eyes on the group leader, and it could involve like participating actively in group, like asking questions or responding to questions in group, and and keeping your questions relevant to group content. That could be a kind of operationalizing of attentive behavior. And then you would create a reward plan for those sets of behaviors that you want to target for the patient. And you could tell the patient that if you spend 2 minutes focusing your attention on the group leader, you're going to get like a reward. So that reward could be a token, okay? And then at the end of, so every 2 minutes that you pay attention, you're going to receive a shaping token, a reward token, and then you will claim a reward with the token that you've earned. And then over time, as the patient improves, you would scaffold the expectation. So you might say, okay, this time we want you to pay attention for 5 minutes instead of 2 minutes. For every 5 minutes that you pay attention, you will get rewarded. And then the next time it might be 10 minutes. So you will scaffold it, and then over time, also fade out the reward itself. And then over time, what winds up happening, if this is working for the patient, is that in this case, their attention would improve over time. So this principle of shaping is very applicable to a lot of behaviors, including cognitive behaviors like focusing your attention, or speaking with a loud voice, like raising your voice. You can shape that as you see fit. Okay. So part of our community reintegration activities include, I think I've talked about this a little bit. When we prepare our patients for discharge, part of what we do is we try to get them ready for interviews. We get them, and after they've gone on interviews, we have them, practice their interviewing skills before they go on those interviews. And then when they go on those interviews and they get accepted, we plan transitional visits for them to visit those housing programs or those, psychosocial programs in the community. And we take them out on trips so that they can get accustomed to navigating that neighborhood that they're going to be moving to, whether it's a community residence or, or a community-based psychosocial treatment program. And then we stay in contact with, the providers in the community. We stay in contact with them. We provide them with our behavior intervention plans. We provide them with, figuring out issues like entitlements and benefits in the community. We consult with them around medications that work for the patient as necessary. Like while we conduct the handoff to the community providers. That's an important part of what we do. And like our handoff is very detailed. It includes all of the behavior intervention plans that we develop for the patient while they were with us. And, it involves sometimes if the patient is going back home, it involves communicating directly with their families and, planning the transition with their families. And it also involves following up with the patients in the community after we discharge them. We follow up with them for, sometimes, up to 6 months and 12 months at a time. Just real quick, I'm almost done to kind of show you some of the outcomes that we've looked at in the context of following up with patients in the community, because a lot of this outcome data has to do with how well patients sustain, after we discharge them. So like one of our like one of our earliest studies, we looked at um, how often our patients get hospitalized at 6 months and 12 months. So we are collected, followed up with patients from 2005 to 2011 in this particular study. We collected some assessment data when they were in the hospital, and then we followed them up in the community after you got discharged. And, first of all, where do we discharge patients? Most of our patients are discharged into community residences, MICAs, and supported apartments, adult homes, back to their families and so on. Only a minority of our patients actually wind up in state hospitals after the rehabilitation. Most of our patients are discharged into the community. In this particular study, it was 83% of our patients were discharged into the community, which compares very favorably to published data. Our numbers rival the numbers from other programs with patients with schizophrenia. And, when we look at, follow-up intervals, what percentage of patients remain in the community? Part of what we've consistently established is that most of our patients, are able to last in the community for 6 months and 12 months without being rehospitalized. Of course, there are some patients within that interval that are going to be rehospitalized, but most of our patients are able to sustain in the community without rehospitalization, and a lot of the improvements that patients show when they are with us are actually sustained at 6-month follow-up, both in terms of the clinical symptoms and their independent living skills, like their hygiene, their room care. Like at 6-month follow-up, a lot of those are sustained and maintained. We've published some data from our program that shows that, our community tenure numbers are quite, remarkable at 12 months. And, some additional data that we've collected continue to look at symptoms, and we're seeing that our readmission rates, are also quite low, even in the most recent study that we did as well, which was this study. Okay, let me stop here in the interest of time. I'm gonna hopefully hopefully I left enough time for some
Hey,
crosstalk
Dr. Ahmed.
and
Yeah, that
some
was
questions.
amazing. Oh,
Yeah,
your patients are so fortunate to be in a program with you. It's just the most thoughtful, beautiful program I can imagine. Thank you, and
thank
thank you
you.
for sharing really great outcome data also. Can you clarify, we have some questions rolling in, and I just wanted to clarify how long is that program, and kind of is that entirely inpatient, that program? And then there's a question here about what if you don't have these kinds of resources, or like the tokens in the store and the staff training?
Yes.
Like, where would you even start working with this population if you were to uh, implement some of these ideas?
When I first joined the program, our length of stay was 6 months. when we started like years ago, the length of stay was like up to a year, 2 years back then. Um, you know, again, because of managed care and, all of the pressures, like, our former medical director, like Mark Ross, who might be in the audience, really
Yeah.
worked with us to really work with managed care to decrease our length of stay. Our length of stay right now, our modal length of stay is between 90 to 110 days. That's what we push for. There remains pressure to keep the length of stay down. What we found is that, especially with the introduction of more evidence-based interventions over the years, we've been able to, and by the way, Donna Anthony was the one who hired me for the program back then. And when Donna hired me, part of what she wanted was to create all this psychosocial platform. So by doing that, we've been able to try to maximize as much as possible the 90 to 100, 120 days that we have for rehabilitation, and try to get a lot of a bang for our buck within that period. And we're still seeing good outcomes even with a shorter length of stay. Um, so that's one consideration. So to the other question, what if you don't have these resources? I think that a lot of the important ingredients, like in social learning and and operant learning as you know theories that you can leverage for treatment, like you don't necessarily, in my opinion, I think it's for us, it's in the context of a broader rehabilitative environment like an inpatient milieu. But if you like these ideas of positive reinforcement of modeling and so on, they're as mundane, to our existence as gravity is to our existence. They are all around us. Like you do it. Okay. Now, you may not know what it is, but you do it. It's a natural way that human beings learn. And because of that, you can leverage that even in your own work as a clinician. You can leverage it in many different ways. If you don't like, I mean, you may not necessarily have a full-blown token economy program, but you could create a token economy light program, okay, for yourself, something that you deem is feasible and supportable by your clinical program. Some state hospitals do that. Like they have a small token economy store that, but of course they don't do it to the extent that we do in the second chance program, you know. But even a little bit of it is still better than none. Now, in terms of training, I'm happy to share resources and ideas. Like if you reach out to me, I can give you ideas about what we've done in terms of training our staff. Like depending on what your resources are, we can certainly game plan around the limited resources that you may have. I mean, it's always possible to do something.
That's great. There's a question here from Deidre Eckold about the opportunity to train family members with the same positive base and extinction type skills, and to what extent do you bring family members into this so that there's a continuity of really a milieu within a family when people go home?
Yeah, like I mean, a lot of the information sharing around behavioral, like learning principles that we share with family members, in my experience, has often involved specialized, individualized behavioral plans. Okay, so like it's always a good idea, and we have, in fact, underscored like making sure that part of our handoff with families for patients who are returning home is sharing information with family members about what we thought helped the particular patient when they were with us,
Mm.
and how they can sustain that plan. When the patient gets discharged, and I find that families are oftentimes very interested in that. Like our patients are adults, okay, they are not children. So you may see more of that, like I think in child adolescent programs. But for us, what we try to do is, when we create the behavior intervention plan and when we start implementing that specialized plan, a lot of the families are going to come to the inpatient unit. So we want them to be exposed to that plan, because we don't want them to do something that's going to, like, mess up the plan, or that's going to create a fidelity issue. So, for example, if we're using an extinction plan around asking a specific question over and over again, we want the family members to do the same thing. So we get them involved in the plan. So that allows our handoff to be rather much seamless.
Great. We are just about at time. Two quick questions. Have you
Yes.
found the 90 to 110 day length of stay? This is a question from an attendee. Has been
Yes.
effective for residents?
We've been able to maintain the same kinds of community retention outcomes, the same kind of community tenure, even with this shorter length of stay.
Right.
And again, this required a lot of, this was not easy. This required important leadership, which we had. It was very stressful for us when this mandate came down, and good thing we had the right leadership for us to kind of help us calm down, help us reconfigure our programming to make it work. And but yes, we have been able to. And I think a lot of the additions that we brought into the program, like the evidence-based group therapies, I think added a lot to our programming as well. Within that short length of stay.
I think there's a desire to potentially connect with you, and we're out of time. And I remember you said that your name wasn't, Dr. Ahmed wasn't on your first slide. Can you let our folks know the best way to connect with you if they want consultation or further information or further training?
Let me put my email address in the chat.
And be
Yes, that's my email address. You can reach out to me. I'm happy to, I'll connect you with my administrative specialist, happy to set up a Zoom call to talk more robustly if anyone has any questions.
Great. And we are over time, and I know you and everyone have places to go. So Dr. Ahmed, thank you so much for really an inspiring presentation. And thank you everybody for joining us today. As a reminder, if you'd like to receive continuing education credits, just complete the evaluation survey that will automatically show up in the browser as we end our webinar. And we hope that you all can join us again on May 8th. But for now, Dr. Ahmed, thank you so much. It's great to meet with you, and so appreciate your wisdom and everything you're doing for so many patients and families. Thank you.
Yes,
Yeah.
my pleasure, and thanks for an invitation. And just a quick response to the question about the prospect of this in a residential setting, the answer is absolutely yes. A residential setting is perfect for this kind of milieu-based program. Yes.
Great.
Yes.
Thank you. See you later. Bye-bye, everybody.